The Final Summit is produced by Bloodstream Media and made possible thanks to our sponsor, Tremo Pharmaceuticals. Visit resethastudy.com to learn more about their work. The Final Summit was also made possible by support from Genentech. Visit genentechhemophilia.com to take a look at how they are supporting the hemophilia community.
The first climb of the 7 summits was Kilimanjaro in Africa. Kilimanjaro is not only the highest mountain in Africa, but the largest freestanding mountain in the world. The summit stands high above the African plains. It was the first time I'd spent so many days on a climb and the highest I had ever been. So many questions ran through my brain as I started my push for the summit. Would I be able to handle climbing to 19,000 feet? Would my severe hemophilia cause any unforeseen issues? Those questions faded to the background when I reached the summit, and we heard other victorious climbers sing the Jambo Bwana, the traditional song you sing when you reach the tallest point in Africa. It was surreal. But as I looked out over the continent, I could see the light of small cities sparkling on the horizon. One question was still stuck in my mind. Why was I able to be here when people who live here with the exact same condition as me were struggling just to live? I wondered if anyone with a bleeding disorder was in these cities, wondering what was wrong with them. I was wondering if Stephen, a young boy I met in Kenya 2 weeks earlier, was feeling better after almost dying to an uncontrolled bleed. Even though I was hiking through the middle of the night, looking up at a curtain of stars hanging over me, my mind was back in that hospital. Bright lights illuminating the patient beds. The sound of beeping machines chirping in the background. Muffled discussions in Swahili and the moans and cries of patients that might not make it. I was shocked by the lack of facilities and care. Multiple people lie in one bed. Some were even on the floor. The smell was overwhelming. I'm not sure what the culprit was, but it was the closest smell to death I have ever experienced. I wondered how anyone could survive this place. Then I met Stephen. He was in the pediatric ward. He came in with pain in his stomach. The doctors thought it was appendicitis and removed it. It might have been the right diagnosis, but that wasn't the end of the story. Stephen had severe hemophilia, and no one knew. By the time I saw Stephen, he had been bleeding for 2 weeks. He was barely hanging on. The deformity in his joints made the physicians I was with assume hemophilia, and probably hemophilia A. But the lab wasn't functional yet. They just had to make their best guess. Stephen lived. And by the time we left the hospital 2 weeks later, he was leaving too. This was one of the first moments where privilege smacked me in the face. It was always something I was aware of, but never in such a profound and blatant way. What did I do to deserve the chance to climb this mountain while others struggle to live? Simply because I was born in a country where care was available? Where my disease was mostly understood? When you're suffering from a painful bleed, privilege can be hard to reckon with. But once you see it, it sticks with you. And I wanted to learn more about that. From Believe Limited and Bloodstream Media, this is the Final Summit podcast, supported through advertising by Tremo Pharmaceuticals and Genentech. My name is Chris Bombardier, and I'm a mountaineer with hemophilia. From 2011 to 2018, I successfully climbed the 7 summits, the tallest mountain on each of the 7 continents. But in between continents, peaks, and infusions, I learned so much more about myself, my disease, and my place in the world. Today, we're talking about Kilimanjaro and privilege.
This next segment is brought to you by Genentech. Navigating hemophilia can be less challenging when you know you have a team in your corner. That's why Genentech created Real Stories, a collection of heartfelt narratives from other members of the hemophilia community. To hear the experiences of other people living with hemophilia A, please visit www.helpwithhemophilia.com.
The summit of Kilimanjaro and just that whole experience in Africa, it just expanded my view of the world. Such a different environment, such different people that I was with. First time in a developing country, it just expanded my mind at what was out there and realizing I knew so little about the world. I think that was a very humbling experience.
Yeah, sure. I mean, I could talk for hours about it.
I am joined by Chris Roberson of the Indiana Hemophilia and Thrombosis Center. I'm really excited to have you on this podcast, Chris.
Yeah, thanks for having me. Glad to be here.
I'd love for you to just share a little bit about the work you're doing in Kenya and that whole project, because it's just really, really incredible.
So I work for the Indiana Hemophilia and Thrombosis Center, the only federally recognized hemophilia treatment center in Indiana. We're part of an international network of hemophilia treatment providers that's largely coordinated through the World Federation of Hemophilia. So in 2010, we took advantage of an opportunity that arose to partner with a then emerging hemophilia treatment center in Western Kenya. And prior to that, there was no means by which patients with hemophilia could be diagnosed. So our program has been committed for the past 12 years to starting with education and advocacy, raising awareness about bleeding disorders, both amongst healthcare providers and the general population. Secondly, ensuring that there is a way to screen and diagnose patients with bleeding disorders. Thirdly, advocating for increased access to care and treatment. So that's both at the international global level in terms of working with organizations like Save One Life to ensure that there's donated product available for patients.
My first trip overseas was to the Dominican Republic in 1998.
This is Lori Kelly, the founder of Save One Life.
So I went there and it was eye-opening. We gathered the patients together, and when they came in, they were impoverished, hungry. They wanted to know about hemophilia, but they were also like, we need factor. I mean, the prevailing need was for factor. They needed the medicine.
But then lastly, really advocating to the local Ministry of Health so that they step in and provide a long-term sustainable mechanism for supporting all aspects of care.
Nothing behind a desk can compare to real life, as you know, right?
Absolutely.
Yeah. You found that out too. And even when you travel to developing countries, say for a cruise or, a vacation, it's nothing compared to actually being with the people in their homes or their communities.
Yeah.
I think having a child with hemophilia, and he was born in 1987, that changed my life a lot, of course. In fact, I quit my job. I stayed home with him eventually.
Yeah.
And started doing my book publishing to meet the needs of the U.S. community. As you know, in 1987, we had no internet, no Google. There's no book on hemophilia. There was a book in the UK written by a doctor, and he glossed over the first 5 years in half a page. And I was like, my baby's 8 months old. I'm dying. What am I doing? I have no idea. And he's like, don't worry. So I said, no, that's a doctor.
Yep.
We need a book by parents and for parents. So that launched that career. And in the process of publishing and doing children's books, and et cetera, eventually the Bayer Corporation actually tapped me to start an international program. I was thrilled because I have a degree in international business and economics. I was ready to do something for the community. And they wanted me basically to go find patient advocates to mobilize the patients in those countries and then lobby their governments and, bring the patients together to get educated.
I remember going there on our first trip, and as you know, the partnership that we're involved in is part of a larger partnership between the Indiana School of Medicine and the Kenyan hospital. So there were IU faculty that had been there for 15, 20 years at the time that we joined. And I remember sitting down with some of the IU faculty that had been there that entire time, and they told us, we've never seen somebody with hemophilia. We don't think there are any patients with hemophilia. Good luck. We welcome your joining this partnership. So, I mean, that was shocking just to hear U.S. trained physicians think that there were no patients with hemophilia.
If I thought we were in the dark ages in the 1980s, they were back in the Stone Age in many ways. There was no treatment. There was no education. There was no community.
One issue that comes to mind immediately is just the misconception in terms of the understanding of what a genetic inherited disease is. So one misconception that we run into a lot is families have a child, they know the child's sick, right? They know
Yeah.
something's wrong when they see these joints blowing up or when they have some type of interventional procedure or trauma and the child just bleeds and bleeds and bleeds. So they know something's wrong, but there is a tendency to attribute that to some type of like superstition, not to think about the medical underpinnings of it. So that's certainly one obstacle that we face. Another is just how resource constrained some of the rural areas throughout sub-Saharan Africa are.
Yeah.
So it's just not the situation that we have in the US where somebody just can have immediate access to the internet, Google something, and at least get a start, at least know what direction to head in.
So I believe when I came on the trip, it was your second trip to Kenya. Is that correct?
Second or third, yeah.
Yeah. I don't know if you remember on that specific trip, the first day we got there was that young boy in the pediatric ward that had a major bleeding issue.
Yeah.
Had you seen that before on any of your other trips? Was that like especially memorable for you?
So it was early on in the program, and there were a number of other experiences like that. So it's definitely not isolated. I mean, unfortunately, it's really all too common.
Yeah.
I mean, I think for people who are new to the hemophilia community, sometimes people just go on Google, they'll Google hemophilia, and then you see these archaic photos that kind of pop up, and you think that must be from a completely different era.
Yeah.
And it'll be, a young male with hemophilia who has a blown up joint. And in the US, you just really never see that. So to go to Kenya for the first time and in those first few trips, to see kids kind of roll up their pant leg with these massive knees or whatever joint was involved was just shocking.
I saw a boy being carried on his father's back, like a 13-year-old boy. He was tall. His foot was twisted 180 degrees.
Oh my gosh.
So he actually walked on his foot backwards.
Oh my gosh.
Never saw anything like that before. Kids that couldn't walk, no crutches. Nobody had crutches. They were in pain, but they never cried. They never complained. Very long suffering. Some of the parents told me their children had died, as they were little children. So that was really eye-opening. And then, as I always do, every country I go to, I insisted on going into patients' homes. So I was taken into some of the poor sections of Santo Domingo and into the home of Santa, who had three boys with hemophilia. She's a single parent. And two of the boys are twins. They were really struggling. I remember going into her little 2-room home and putting my hand against the wall, and it almost fell over because it's flimsy. It was just kind of just being held up, propped up. They had a giant propane tank right in the kitchen. And sure enough, our partner there said, yeah, there's fires, people die every year from explosions. So I'm getting a real sense of, oh my gosh, there's transportation problems, there's housing problems, there's fuel problems, there's electricity problems, there's unemployment.
In Kenya, I found it surprising, but really when you think about it, it's understandable that there are so many healthcare needs across the board, like primary care, other specialties, everything.
Yeah.
And like you said, you've been in the hospital there, you know how chaotic it is. They have 2 patients in each bed. It's overwhelming. So that was surprising for us, going there to support our Kenyan colleagues and thinking, okay, when we go on a trip, they're going to be there right next to us the entire time, focusing on the hemophilia patients, and to see them need to be pulled away for other really acute needs that pop up is definitely a challenge.
So that kind of seed was planted in my head that it's not just about educating them. That's one thing. It's hard to educate people about growing crops when they're in front of you starving to death.
Right.
They need factors. So that's where the idea for eventually Project Share came from. I went back home and reached into my database and said, if anybody has any extra factor that is about to expire, you don't need, or you switched, send it to me.
We have the benefit now of seeing those patients, kind of following them long term and seeing drastic improvements in their quality of care. But still, there's so much work to be done, right? So at this point, 12 years into the program, we have about 500 or 600 patients on the kind of national registry. That's maybe 25% of the total patients in the country. So even on trips now, we have a team that's in Kenya today.
Oh, wow.
They left last week and they'll be there through next week. They're still seeing patients like that who are showing up for the first time to be diagnosed. So it's kind of like both ends of the spectrum. I mean, on the one hand, it's sad. It's really sad to see and to know that there are patients out there living like that. And then on the other hand, it's really rewarding and inspiring to know that you can make a difference when you're able to kind of diagnose them and treat them.
I volunteered for a couple of years with the World Federation too, and I studied their model, how they did it, and I learned a lot. We don't need to duplicate what the World Federation is doing. They are experts at what they're doing, and they have a huge reach. They take kind of a top-down model where they give help to the engines, if you will, the health ministries. They work directly with health ministries, with the major clinics, the major hematologists, the patient leaders, and the national patient groups. What I wanted to do is do something different, and also recognizing that's not my expertise. It's not my interest. It's not my expertise. They're already doing it. They're great at it. Let's do something different. I love being with the families, just like in the US. I love sitting with families, hearing their stories, connecting with them. 32 years later, I'm still connected with the families that initially contributed to my book. Now I'm in touch with their children who are now grown and have kids of their own. I mean, it's like a whole cycle has passed. So I recognize that's where my strengths lie.
At this point, our trips are completely different than they were when we started. When we started, it was a little more of a one-way kind of, we were bringing education that they didn't have access to and providing that type of training to our Kenyan colleagues so that they could be the leaders of the program. At this point, they are hands down the leaders of the program.
That's awesome.
We're going in much more of like a supportive mentorship role than we are kind of, training them, so to speak. But there's still a lot of work to be done. I mean, I mentioned earlier, we've diagnosed about 500 patients. There's still probably 75% more that need to be diagnosed. But I think my long-term hope is that the Kenyan program becomes recognized as a model that other countries can replicate.
Yeah.
It's really disheartening to think of how many other countries don't even have the type of center that exists in Western Kenya, and how with even modest kind of investments and resources, how much of an impact that can have.
Absolutely. Yeah. I mean, it's changed the lives of 500 people in Kenya. And then even in Kenya, it's a big country. So There's still a lot of kind of country to cover there. So like, how do we, as people that have experienced what we've experienced, help open people's eyes to what's going on in specifically the hemophilia community, but also just in the healthcare, space where there's this drastic inequity in care? Like, how do we bring more attention to that and help people recognize what we have here?
Well, that's not an easy question, is it?
It is not.
It's such an important one, but it's so difficult to answer. I think it starts with really being thoughtful about the right to healthcare. It's like, it's really the words that we use and how we think about it. I think you have to start with believing that there is a fundamental right to healthcare.
Yeah.
And that might be a bit of a politically charged statement, but I think it's true. And there's no better place to really appreciate and think about that than being in Kenya and seeing somebody with hemophilia and asking yourself, like, should that be considered a privilege for them to have access to clotting factor to treat a bleed? And of course, the answer is no. Like, they have a right to be treated for hemophilia. And to me, that is generalizable for all people in all places.
Yep.
I think the more that we educate ourselves and learn about, especially patients with chronic diseases in underserved environments, that to me, that's one of the most important starting points.
I never felt guilty that my son had hemophilia. I certainly didn't give it to him.
Yeah.
And I never felt guilty that we had access to medicine, because that's the way it should be. But what I did see, I'm more of a problem solver rather than, it's kind of a waste of time to say, oh, that's terrible, and feel sympathy and pity. Those are not good emotions. But I did say, there's all this factor in the US and they have none. How can we get it to them? That was really just, let's go into problem solving mode.
We're really working to establish a community where they can interact with other people who have the same disease. And that's been another real rewarding kind of aha moment, just to see kids interact with somebody else with hemophilia. And then even to have somebody like you there, who to me is such a source of inspiration, because they can see a positive future where they might not have been able to envision that.
Ever since that trip to Africa, I've been more connected to following the world news and realizing there's so many different cultures to learn about. I just try and soak up and absorb all the stuff and realize that my preconceived notions and the things that I might have in my head might be wildly wrong, and that's okay. That's been really powerful to like have that realization and be open to these different narratives that before didn't even exist in my mind. I think I had this like deep-seated notion that privilege existed, and I was probably experiencing that in a lot of different ways. But when you're confronted with something that's so powerful, you can't help but have that change you. And if I didn't have that experience in Kenya, I don't know if I ever would have had that realization. At first, it racked me with guilt of why did I end up with this privilege? Why am I in this space? Like, what did I do to deserve it? And I mean, the definition of privilege, like you didn't do anything to deserve it. It's been fun to kind of, shift that focus from guilt to like, well, you can feel guilty about it, but then you should do something about it to change it, share your privilege with others or change the, systems to help other people have the same access to the services and medication and so many other things that I have. So I'm still growing in that way and realizing other places that I bring it to privilege, but at least it's in my brain now. I'm able to recognize it a little bit.
Chronic pain can be caused by many things, but if you have severe hemophilia, there's a chance that some of your pain might be the result of what's called hemophilic arthropathy, or HA for short. That's why I'm excited to tell you about the Reset HA study from Tremo Pharmaceuticals. Tremo is founded with the goal of developing and delivering non-opioid pain therapies for people living with pain. Tremo's Reset HA study is a clinical research study for people who experience joint pain due to hemophilia. The study is evaluating an oral non-opioid investigational drug designed to be taken once a day to see if it may potentially help relieve joint pain and improve physical function in people with hemophilic arthropathy, HA. You may be eligible to participate in this clinical research study if you are between the ages of 12 to 75, have been diagnosed with hemophilia A or B, have chronic pain in one or more joints, and do not take opioid medication more than 4 days a week. If you are interested in learning more about taking part in Tremo's Reset HA study, visit resethastudy.com. That's RESETHA study.com to find a location near you. Reset the way you manage your pain. Visit resethastudy.com today.
When privilege smacks you in the face and becomes impossible to ignore, you can do one of two things: accept it and do nothing, or work to help. Privilege exists in so many aspects of our life. From healthcare to race, we often don't see where we are benefiting from simple circumstances out of our control. It's important that we take a look at our surroundings and recognize these differences. Recognizing privilege does not diminish the hurdles and obstacles we have each overcome. It took me a long time to realize that my guilt surrounding my access to healthcare doesn't mean my difficulties with depression, fear of needles, or painful bleeds weren't hard. I'm proud to overcome these difficulties, but I also realized that my pain doesn't negate what others are living through. In fact, those very difficulties, the ones that I live with, turned out to be a spotlight, illuminating how fortunate I was to live in a place with regular access to healthcare. At least I have support for my difficulties. Thanks for listening to The Final Summit, a podcast from Believe Limited and Bloodstream Media, supported through advertising by Tremo Pharmaceuticals and Genentech. Be sure to rate and subscribe to The Final Summit on Spotify, Apple, or wherever you get your podcasts, and share this episode with a friend. Tune in next time as we go to South America and Summit Aconcagua.
And he kind of envisioned this hiking program, and on the side of that mountain, he came up with the name Backpacks and Bleeders.
I'm Chris Bombardier. Until next time, find your outside.
To learn more about Chris's work with Save One Life, visit saveonelife.org. The Final Summit was written by Chris Bombardier and Drew Johnson, produced and directed by Keith Cornela, edited by Greg Bernhard, artwork by Christina Newhart, executive produced by Patrick James Lynch. The Final Summit was made possible by advertising support from Tremo Pharmaceuticals. Visit resethastudy.com to learn more about their work. The Final Summit was also made possible by advertising support from Genentech. Visit Genentech Hemophilia to take a look at how Genentech is supporting the hemophilia community.